Good morning, good afternoon, depending on where you're at in the country. Hopefully all is well with you, your staff, your families, wherever you happen to be. This is the COVID update for 30/31 as part of our continuing involvement in keeping our clients updated as part of our COVID-19 toolkit. Obviously, these webinars are to keep everybody updated on the newest announcements from whoever it happens to be. And I know that some of this information you're going to say, well, I've already heard that. But again, we have more than 150 people signed up for this webinar. So, we don't necessarily know what everybody understands about COVID. So there may be some repeats. And as you work through this process, know that part of this whole process of the webinar is so that you can ask questions. So, as you have questions, don't hesitate to type them in to the question box. And we do have a moderator, Nicole Mark, our marketing manager, who will be working over those questions or any support issues as they come up. Okay, so starting off recent updates, and we talked about this. We even, my original COVID-19 webinar and the COVID webinar from last week, we anticipated that obviously shelter in place, lockdown orders, social distancing, all of those, depending on your region, were going to be extended. And now they have been extended federally till April 30th, even though obviously the federal government is hoping that the peak occurs before April 30th, but that whole flatten the curve, where's the peak going to occur? That's all part of this, that they're extending social distancing guidelines. But again, those are obviously going to depend on your geographic region. If you're back on the East Coast, specifically in some of those high population density areas, those are going to be even more difficult. Over on the West Coast, we've got Florida, not Florida. Florida's not on the West Coast, is it, Chad?
No.
No, we've got Washington, Oregon, and even down to the state of California. They have different social distancing guidelines. Even here in Utah, we've now got the stay home, stay safe guidelines and shutting down everything but essential businesses. So the OCR has issued a bulletin on, obviously the OCR is the Office of Civil Rights, so it is a bulletin on civil rights, HIPAA, that to keep entities in mind that they have obligations under the HIPAA laws, that those laws prohibit discrimination, and just, again, making sure that even though they've suspended HIPAA enforcement actions with regards to telehealth, HIPAA is still a concern, and we want to make sure that we're protecting PHI. Okay, so the OCR has, again, given us a bulletin that tried to remind us that there is this concept of discrimination, civil rights enforcement, and HIPAA enforcement. The HHS is committed to leaving no one behind during an emergency, and this guidance is designed to help healthcare providers meet that goal. Okay, persons with disability, with limited English skills, or needing religious accommodation should not be put at the end of the line for health services during emergencies. Our civil rights laws protect the equal dignity of every human life from ruthless utilitarianism. Okay, that's the OCR director and the OCR director operating under the auspices of the Department of Health and Human Services. So just again, a mandate that HIPAA enforcement, that the Office of Civil Rights is still going to be looking into these, and these will be, there's a look back period for this. So there will be potential enforcements. Obviously, we are in an emergency situation. We need to make sure that we're dealing with patient care first, but we also want to consider that HIPAA. And again, this gets into our mandate here at Healthcare Compliance Pros with regards to compliance in general and HIPAA specifically. Okay. CMS has put out a request that hospitals report COVID-19 testing data, okay, daily reporting regarding bed capacity. All of that is going through the CDC National Healthcare Safety network, and this nation's nearly 4,700 hospitals have access to testing data that's updated daily. This data will help us better support hospitals to address their supply and capacity needs, as well as strengthen our surveillance efforts across the country. America's hospitals are demonstrating incredible resilience in this unprecedented situation, and we look forward to partnering further with them going forward. Obviously, trying to correlate data. That's the thing that we're behind on, obviously testing data in general, but just data correlation overall at a federal level. I'm watching those same things that you are. I'm looking at Cuomo talking about New York, and he's got his daily updates, and we're seeing all of that new information. And the CDC is publishing information that's updated all the time. Links to the CDC data are included on the COVID-19 Toolkit webpage. Okay. I've got a panel. I've got Loretta Maddox, who has just joined us as a new compliance specialist and account executive. I've also got Chad Schiffman on this call. Any thoughts on that with regards to testing and where we're at with testing? Chad and/or Loretta?
I think I was muted. I'm sorry. Well, it's constantly evolving, I think, is the biggest thing, and we're seeing different things happening across the country in different localities. Like here in Florida, it might be different than, say, we're seeing in California versus what we're seeing in New York. So it's just real interesting to me to see what's going on there. And we expect the numbers to obviously inflate drastically by the amount of tests that are being performed. Seeing more positive diagnosis and also less or more negative diagnosis as well. So it's going to be interesting to see how it unfolds over the next couple of weeks.
One of the interesting, but go ahead, Loretta.
No. I was just going to say I agree. I think we are seeing the spike just like we all expected, because we have more availability to testing. Me being in California, we've definitely seen some of the numbers rise, but I think it's just because of the availability of the testing now to actually get that data. That real data.
Yeah. I would say that another interesting thing that we're going to be looking at long term is this idea of recovery, or those who have been through the virus. It's a serum test. It's not specifically a virus check. So the testing for that is a completely different process, and we don't know how many people have actually gone through it, maybe thought it was a bad cold, maybe even thought maybe I do have COVID-19, and in actuality they did, but it didn't require any hospitalization or anything other than self-isolation. So those numbers are going to continue to rise over time, and we may not know even for months or even years after this pandemic is over what the true numbers are. That may be something that is run as part of a normal blood test for years in the future, looking at, hey, we want to look for the antibodies as part of a serum test just for people who are doing general blood work, which will be something to look for in the future as well. Okay. Okay, the OIG has issued a statement about minimizing burdens on providers. The OIG is coordinating with HHS and CMS to support the healthcare's response and making sure that they're aggressively investigating bad actors who are exploiting the crisis, but they're trying to make sure that there's not a tremendous amount of administrative overhead. As you saw, OIG came out with the whole telehealth and not enforcing actions with regards to HIPAA compliance and telehealth. There have been more announcements on that. We're going to talk about CMS's release that just came out yesterday later on in this. But, if healthcare organizations need extensions to meet OIG deadlines, they are encouraged to contact the OIG, okay? In fact, we just had an OIG auditor reach out to us today regarding an audit that was being performed with one of their clients. So the OIG is still working. They are working at home, as we'll see in the next slide. For any contact during this emergency, the OIG will carefully consider the context and intent, and the OIG encourages electronic submissions of any materials, as ordinary mail has been suspended with regards to the OIG especially in light of the OIG workforce is currently teleworking. So Chad, that auditor that Laura Serrett, our auditing manager, spoke to today was telehealth or telecommuting today. Is that right?
Right. She's working from home and just asking for some clarification, but yeah, so she's teleworking, and so is another one that we've worked with on an SRA.
Yeah.
It's interesting getting them data now that we can do it electronically versus them wanting it in the mail. So that's kind of a plus for us.
Yeah, that was an interesting thing where you've got all of these electronic systems in place, but the OIG was still working with snail mail for a lot of their data submissions. Obviously, now they're moving to electronic submissions for that. But I think the point of that was, as you just heard, we're still talking to auditors. Audits are still going on. You know, the federal government, in a lot of ways, is still working. And when we talk about the OCR, we talk about HIPAA enforcements and complaint management. We talk about the OIG with their auditing. Those activities are still going on, even when we're talking about, you know, that reduction in administrative overhead. There's still some of that going on. Now, the Department of Labor has published materials to aid employers with compliance with the Family First Coronavirus Response Act, you know, paid sick leave, extended or expanded family and medical leave. Those links to the Department of Labor materials are included in our COVID-19 toolkit. It also helps expand on some of the definitions of what employers can do with regards to time off, whether they're in a critical position within their workforce. Chad, did you want to expand on that just a little bit?
Yeah, you know, and then just some of the questions with regard to how many within each employer does it qualify for, and the different roles. Those are some of the concerns that we've been being asked questions about. So, you know, they've been very intricate, and each office has been had to be handled basically case by case. So as people have questions on these, we've been trying to do our best to break it down for them and provide them formal responses. And it's been real eye-opening to learn about this, actually.
So, you know, that comes specifically into this concept of essential workforce. It's very interesting that they're defining, you know, medical workers, you know, in the healthcare industry, depending on their role as essential workforce. At the same time, that these same practices, you, our clients, are having to close offices. They're not seeing the patient, and close for non-essential patient visits, which means that you're not seeing the patient visits, which means ultimately you're not going to be able to bill for those services, which means that, you know, that reimbursements are going to be declining as well. You know, we had employers reach out to us, or clients reach out to us about closing certain offices. What's their responsibility on that? How do they define essential services? Those are all things that are available within the COVID-19 toolkit, and you can ask those questions as part of this process. Okay. Now we do have some questions, but we do have some questions, some frequently asked questions that we're going to get to next. But please submit your questions beyond just technical support questions, and we can go ahead and answer them. First of all, what is the deadline for MIP submission this year? If I don't submit anything, will I receive a negative adjustment? Now, there's great news on this, but I'm going to let Chad reply to this. And I know we've even had some questions that have come in specifically about this, right, Chad?
Right. So instead of the end of March, you have all the way until the end of April now to go ahead and submit your MIPS data. If for some reason you're not able to submit data, the good news is there's not going to be a negative adjustment. There's an extreme hardship exception that applies. So that's good news for practices who aren't able to. But we have seen some practices who have been able to submit. Our question with this is, you know, if they're not going to really be negative adjustments per se, you know, how is it going to balance out? So,
yeah. Well, yeah, who's going to get positive adjustments, and where's the money for positive adjustments going to come from? Obviously, the quality payment program has to be revenue neutral. I know that there's some bonusing that can kick in. I know there's various pieces by that, but the reality is it's supposed to be mostly revenue neutral. So if everybody gets a pass on neutral payment adjustments, then there shouldn't be a tremendous amount of negative payment adjustments or any. How will they go about compensating positive payment adjustments for those that do score? Okay. Now, the issue with this is if you can submit, you still should, because you want to make sure that the mechanisms are still working. Okay. You want to understand what your scoring is. You want to be checking for, quality measures. Quality measures can be updated. The scoring mechanisms can be updated. So, if you have the time, if it's not a tremendous amount of overhead, you still should be submitting, or at least, moving with your MIPS adjudicator to determine your scoring, so that you're at least working through the process. I wouldn't just take a vacation from MIPS, because you're going to have MIPS next year as well. We might as well, work the process. Okay. All right. Number 2, and we're going to be turning this over to Loretta. She has some thoughts on CMS flexibility updates. Here's the link to those updates, and you can go to CMS specifically. There's a bunch of information about telehealth and some other talking points. But Loretta, you did some research on this, right?
Sure, I did. And I'm not going to spend a ton of time on the telehealth portion, because I think we've talked about that quite a bit. But some things that jumped out to me in the initial review are things that have to do with supervision requirements. Medicare is changing the supervision requirements to allow those physician supervision, when it's required for direct supervision, can be done virtually using real-time audio and video technology. Also, there are some changes or waivers for the Stark Law, and a good example of this, because I'm not going to get too detailed into it, there's a lot of information which is also going to be available in our toolkit, but an example of this might be if a hospital decides to rent physician space at a below fair market value, or even maybe for free, in order to allow them to see patients that need to be treated during this crisis, that's not going to be considered a Stark Law violation. So there's lots of information regarding that's in this guidance, and I would certainly encourage you to check out our toolkit, and then of course ask if you have specific situations that you're concerned about, so that we can help you work through this process.
I thought an interesting part about that supervision, Loretta, was this concept of they just need to be available via audio or video to provide supervisory oversight if needed. So it's almost, in actuality, it's almost a complete repeal of that, because when is that supervising physician not going to be available by telephone if necessary, as opposed to being directly available to them supervisory wise for that patient appointment in office. So now we have a telehealth situation with regards to that supervision, which again expands the ability for those mid-level providers to provide telehealth services, specifically, again, because they have that supervision exception now about direct supervision versus virtual supervision.
Right, exactly.
Okay. Any thoughts on that? Did you read that over, Chad? Were there any highlights that you wanted to bring up about the flexibility updates, or are they all posted within the toolkit itself?
Yeah, we've got them all posted within the toolkit. I think that's a good place to turn to look and review that document. It's pretty insightful. There is another one, the CMS update, that we may want to talk about. Should we talk about the payments to providers, the advance payments?
Yeah, and I think that's, there's going to be information about advance payment to providers. They're still working through how they're going to handle those requests. But part of the Families First Coronavirus Response Act includes funding for advance payments for up to 3 months to providers based on their previous CMS billing volume. So that will allow you to bring money in as far as advance payments to possibly be paying payroll, rent, other vendor contracting, those kinds of things that need to be paid. Do you want to spend a little bit of time on that, or did I just steal all of your thunder on that one, Chad?
Oh, totally fine. I just wanted to let everyone know that we did add the fact sheet into that for that as well. And basically the purpose of it, like Eric alluded to, was the 2.2 million part of that package was the accelerated and advanced Medicare payments for emergency funding. This is typically in place for like natural disasters that happen. But in this case, due to the coronavirus outbreak, they've decided to do it as well. And the payments can be requested by hospitals, doctors, DME suppliers, and other Part A and Part B providers. So if that's something you're interested in, we have definitely added that to this toolkit.
Yeah, and again, try taking some of the administrative overhead in part of that application, but you'll want to read through that that CMS update for information about that. That's on the toolkit. Number 3, and I'm going to let Chad answer this one. We did see this even on Google. I saw this question come up. But what about devices such as your Alexa? I've got my Google Home. In fact, I have a Google Home sitting right here on my desk. I don't use it for anything except for alarms or to turn the lights on here. But what are you doing with those remote devices? And what are you doing with regards to they're listening all the time? Do you have a responsibility for them with your remote workers potentially handling PHI or company information, those kinds of things around those Google devices or Alexa or Siri? So give me your thoughts on that, Chad.
Well, I know that Alexa came out recently and said that, or Amazon did anyway, regarding Alexa, and said that they've made it HIPAA compliant in certain ways. But still, the concern with these devices is to have them in the same location where overheard communications can happen involving PHI. That's often the concern with them, and that are they snooping potentially to calls and conversations that you're having involving PHI. So our recommendation for those is to definitely have workers remove them, especially if they're using, having phone conversations and such involving PHI. Because obviously they shouldn't be talking about PHI with their family members in the same room. But, if they are on the phone and those types of things, then it would be a good idea to definitely remove those from those rooms to prevent that, I guess, snooping, for lack of a better term, that could potentially happen.
Yeah. And again, Google has even come out with the fact that they're looking at conversations. It's part of their AI training. They have interpreters who are actually monitoring what the Google AI is doing with regards to those conversations and how they're doing interpretation. All of that is theoretically supposed to be de-identified, but since you don't have a business associate agreement in place for anything that may be translated as part of that remote assistance process, either with Alexa, with Apple, or with Google, those are considerations to take into with regards to HIPAA. Okay. Any other questions that anybody wants to bring up from the panel? I don't see any questions that have come in from our attendees, and more than 65 attendees to this session, and I haven't gotten a single question. So while we're waiting for some questions to come in, any thoughts on the previous week or the week ahead with regard specifically to compliance?
I just think it's going to be a constant evolving process. So we're just trying to keep our eyes on everything that comes out. There's so many updates happening every day, and each state has different guidelines and each county has different guidelines. So we're just trying to do our best to stay afloat with everything and encourage clients when they have questions to please feel free to reach out to us, and we'll do our best to help you answer those questions.
So information under COVID-19 on practice operations as it applies to HIPAA, as it applies to billing, as it applies to telehealth, and especially as it applies to infection control, are specifically under the mandate of HCP and our delivery of compliance with regards to COVID-19 and our mandate for our clients. And we had a question come in: do we have specific telehealth HIPAA guidelines published within the COVID-19 toolkit? And there are some specific guidelines along with some acceptable use, some remote work policies, and some mobile or bring your own device policies with regards to COVID-19 in the toolkit. So yes, we do have some information specifically about telehealth guidelines and COVID-19. And we have obviously published other webinars, previous webinars where we've spoken about telehealth specifically, And those webinars are linked, including the questions that were asked and answered as part of that are included in those webinar links as well. So there's a lot of guidance within the COVID-19 toolkit about telehealth, specifically about HIPAA guidelines, some specific remote work guidelines. There's even some HR guidelines with regards to utilizing employees' resources. That's the internet, their phones, their cell phones, what you may have responsibilities that way as well. Okay. So that's our 3/31/20 update for COVID-19. Again, we're doing a weekly webinar, your chance to ask questions as well as get updated and links to additional resources that the government is putting out there, all in one place here with Healthcare Compliance Pros. Okay. And again, I want to remind you, if you're not signed up for the toolkit yet, get signed up for the toolkit. That's available to anybody who's using us under especially our OSHA services. Okay. I want to thank our panelists, Loretta Maddox and Chad Schiffman. Again, Eric Christensen, Director of Client Services here at Healthcare Compliance Pros, thanking you for attending. And again, reach out to us if we can provide any support to you and to your organization around the COVID-19. Okay. Thank you and have a great day.